All right. All right. Hi, everyone. Thanks for joining us tonight. Dr. Navity, Dr. Santana, Michigan Center Regenerative Medicine. And we're just doing a series now of monthly podcast or webinars where we'll be discussing various different topics. And tonight's topic is shoulder pain. So intentionally, we're keeping these somewhat informal, where Dr. Santana and I just bounce ideas back and forth, our approach to treating these sorts of conditions and how we incorporate regenerative medicine into those treatment plans. So we'll just kind of start with a general presentation for shoulder disorders, patients who say have rotator cuff issues. How do you see those typically present?
Yeah, so typically when patients come in the office complaining of shoulder pain, there's you kind of just run down the list of the most common shoulder issues that patients would have, right? So the most common one would be just like a regular shoulder strain, where after doing like a certain activity, they start to hurt their shoulder. Typically those, you just kind of wait with some conservative management. You can put some ice on it, rest it, some ibuprofen, that usually takes care of the issue. If the problem kind of lingers on for a little bit longer, you kind of start going down your algorithm, what other things it could be. So most commonly, it could be a shoulder impingement, where you can have a little bit of a rotator cuff tendinosis. On the more severe side of the scale, you can have degeneration like osteoarthritis, or even something like a rotator cuff tear or a labral tear.
Okay. Yeah. Features-wise, as far as like how people either historically how those present, or some exam findings that might make you think one or the other.
So usually, like when patients complain of shoulder pain, usually the most common symptoms that we see is pain at the site, and also difficulty with range of motion, right? Usually they're not able to kind of lift their arm beyond 90 degrees, or if they're reaching over or trying to brush their hair or something like that, it's going to be harder to do. So there are some provocative tests that we do that to try and elicit certain areas of pain, and then from there we're able to kind of see what the issue is. So, you can do range of motion exams to help you kind of differentiate whether it's a rotator cuff issue or not. You can do tests where you kind of test the stability of the joint to see if there's any laxity going on in there. If there's a prior history of dislocation. You can do just overall just doing palpation in the shoulder as well. And then, you kind of get a general idea where the source of the pain is. And then the next step that we do here in the office is we do an ultrasound evaluation. So we can kind of visualize what the problem is.
Okay. So you talked about some range of motion things, in particular instability. Mm-hmm. You mind talking a little bit about what that means?
Yeah. So there's certain exams that we could do where you kind of test the stability of the shoulder. So you kind of put it in a certain area where you're slightly getting the shoulder off the joint, and to see if there's going to be replication of the pain, or is there going to be discomfort by doing that. You can also kind of do a test where you kind of have the shoulder kind of hang down and maybe put a little traction on there. Sometimes you can see a little divot, which can mean there's some subluxation. Is that what you kind of talking about?
Yep. And then from a history standpoint, are there any particular things that maybe think somebody has one of these subluxations or instabilities?
Yeah. So there's certain medical diagnostic conditions that can make somebody more, I guess, prone to subluxations and possibly even dislocation. So one of the most common ones that we see here in the office is somebody who has Ehlers-Danlos syndrome, which is a genetic disorder where the collagen fibers are in disarray, so it's not as stable, and you get a lot of ligamentous laxity. A lot of patients are able to, they can dislocate their shoulders quite easily. There's different things as well too. So different ligaments and joints of the body can also get dislocated as well. So that's a fairly common one. Other than that, the other reasons that you can get a dislocation or subluxation usually due to the traumatic experience, right?
Yeah.
What's your experience with these types of?
So the traumatic ones are probably the ones that I more commonly see. Yeah. In particular, like hockey players getting hit into the boards. Yeah. Oftentimes will dislocate, maybe not fully dislocate, but it'll pop out, pop right back in. Yeah. Swimmers, in particular butterfly swimmers, a lot of repetitive overhead activities. that just puts a lot of strain on a structure in the shoulder called the labrum. We think of the shoulder being a ball and socket joint. It's really a ball and a slate, and then the cup or the socket comes from a hard cartilage called the labrum. And that, just like your nose, that cartilage can get stretched, and it can allow that ball to dislocate, relocate relatively easily, the subluxation.
Yeah.
So whether it's a genetic reason for that cartilage to be a little loose with EDS, Ehlers-Danlos, or multiple trauma, repetitive type trauma, like hockey players getting slammed into the boards, swimmers with their overhead activities. Those would be probably the more common reasons that patients present with that subluxation problem for their shoulder issue. I would say more common than that are people who come with rotator cuff or osteoarthritis of the shoulders.
Yes. Yep. So those guys, I just kind of go back to your analogy. So the other one that I like also compared to shoulder is like a golf ball on a tee.
Mm-hmm.
So you have the big ball and you have the small tee that's on there, and you have all the capsules and rotator cuff tendons kind of holding the ball on the tee. So I like that one. But yeah, for osteoarthritis, again, very common thing that we see here. Very common source of pain for a lot of our patients. Even just doing menial tasks like, fixing your hair or putting on deodorant or something like that could be painful and kind of uncomfortable. So those patients we kind of see here. So how do you go about kind of processing your treatment options for patients that come in with osteoarthritis?
Yeah, so we've like we've talked about on previous sessions or webinars that we've done. I think Dr. Santana and I spend a lot of time on diagnosis, because proper diagnosis is required for the proper treatment. The reason for your symptoms is really important for us deciding what's going to be the right treatment for you. So someone coming in, we've spent the time